Hello, everybody. Welcome to today's webinar on ageing and frailty. We'll be starting soon. We're just waiting for a few more folk to join us. In the meantime, what we would like to do is if we could, we're going to put up a word cloud, and we'd like you to put in the word cloud if you follow the link to let us know what sector you're working in. And then once we've had a few more folk arrive and we've started to fill out the word cloud, then we'll start with the session. Thank you. So if you could put the word cloud up, please, Marina, that would be great. Thanks. So for those just joining us, we're just putting up a word cloud, and it is what sector do you work in? The link is in the chat, so if people could that would be fantastic. It also should be on your screen. Great. Well, we're seeing quite a range of responses coming in, a real range of sectors that people are reflecting, so that's fantastic. Thank you for that. So we're going to start sharp today. We will also be finishing on time. Hopefully everybody can hear me. Well, welcome to this ageing and frailty webinar, as I mentioned. Delighted to have so many of you. It's such a fabulous turnout. My name's Fiona Woodall. I'm lead for indicators at Healthcare Improvement Scotland. I'm joined on the call from a number of colleagues. You'll see Paul Bon and Pio Minto, who are the co-chairs for our development group, but we also have on a number of colleagues from my own team and for Care and Dementia Programme at Improvement Scotland. And we're all on hand to take you through today's presentation and to answer any questions or to respond to comments that are in the chat. So welcome to Jane Miller and James Batty as well. So thank you for that. In this session, we are going to present our ageing and frailty standards, share with you some of the details, our reflections, and how we think they'll impact on cases, their care partners, staff, organisations and services, all working in the field of ageing and frailty. So that's our plan for today, and Paul and Pio will be presenting to you shortly. But it's really important that we also hear from you as well. And we've already got 400 people on the call, so it's going to be quite hard to have that sort of personal interaction. But we hope that you'll use the chat function to perhaps comment or to ask a question. But we also have a number of word clouds that we will be running through the session, and we really like you to participate in that. Before we bring up the word clouds, I just want to remind people of some of the housekeeping. This will be very familiar with you. Teams has been around for quite a while. So also on that note is our email address should you wish to get in touch. So as I say, the session is being led by myself, but we have Paul and Pio on the call, and they come with a real wealth of experience in terms of ageing and frailty. And a number of the sectors that we saw in the first word cloud, you'll recognise the expertise, and you'll also see the overlaps with your own sectors. So we've got a really broad range of things that we want to touch on today. Before we go into that, I would like you to, if Marina, you could put up the next word cloud, and what we want to have a sense is some of the things that are important to you or some of the challenges that you may face in delivering services to people experiencing ageing and frailty. So our first question is really thinking of it from the perspective of people trying to access services. What are the challenges? So what is the main challenge that people trying to access your service face? And that would be really, really helpful if you could put that into that. I'm seeing a few ones coming up. So these are the things that if you could share with us, what is the main challenge? And then what we'll do is this will allow us to maybe reflect on these as we go through our presentation, but also to capture at the end and for us to have a sense of how our standards might help you to address some of these challenges. So there's a few that have come on. There's ones around time. I see waiting times, waiting list, resources availability, and unknown pathways and awareness. Okay. So there's a few things in there from the perspective of people trying to access services, and that's really good food for thought for us. But of course, we're also really interested to hear in some of the challenges that you face within your service delivering services. So Marina, if you could put up the next slide, and that we'd ask you to complete that. So that's the biggest challenge that you face in delivering your services. So we've heard from people trying to access services, and we would like to hear, this is about people who are delivering services. So what are the kind of challenges that you are facing? Okay, thank you for those. Okay, so for lack of knowledge, staffing, resource, time and demands, time and resources, time and capacity, recruiting staff. So there's a few key messages in there. Okay, thank you for that. So what we'll do is we'll revisit those at the end of the session, and I can see people are using the chat, so that's really helpful. We've got people, Silas, Mary and Steph will be monitoring the chat. Okay, and you probably saw at the start as well that we are recording this session, and the session will be available from the Frailty Learning System website. Not the, doesn't quite trip off the tongue, that one. I hope I got that correct. Will be available after the presentation. Okay, so thank you for that. So what we thought we would do is I'll give you a very small piece of background about the standards, where they sit in terms of landscape. And then I'm going to pass over to Paul first, and then Pio, who's going to talk through some of the detail of the standards, some of the thinking behind the standards, how we've got to the standard, and then some of the impact. So that's what we're going to do next. So many of you will be very familiar. Or can I just note here that some people can't hear anything, so I'm going to ask some of the technical team if they could maybe support those that are struggling to hear. But back to standards. Some of you will be very familiar with the standards that Healthcare Improvement Scotland have developed over the last 25 years. The older people, acute hospitals, our pressure ulcer standards, food, fluid, nutrition, infection prevention control, as long as a host of the national screening standards. And I thought it would be useful just to put on this slide a reminder about what our standards. So obviously they're there to support people who plan, commission and deliver services. But a key part of the standards is also outlining what people who are trying to access services, or their carers, care partners, support network should expect to experience. So we're really clear on this one. It's not about what currently does happen, what should happen. So that's a really important distinction. They're part of a wider quality management system, and I've got a bit more information about that in a moment or two, because they allow us to benchmark. And when we benchmark how we're doing, that also allows us to think about areas of improvement. And these are really key parts of standards. They also set out what's we should be delivering in terms of nationally consistent. So regardless if somebody is presenting at any of the health boards, and whether that service is coterminous, that people should expect to receive the same high quality of service. However, we're really thoughtful that there needs to be local determination. And so it's about how local services would work with local partners, including people with a living experience, around how those standards are rolled out and implemented. To give you an example, people should be able to access information in a format and language that's right for them. Those languages may vary across Scotland depending on local populations and communities. So that's where we want national consistency in terms of what people can expect, but there may be variation because of locality. And it's really important that that partnership working is there. Just to say something very briefly about the principles for standards development, and there's some bullet points on here, and to say, and because the reason I think this is really important is because the standards that Paul and Pio are going to describe have all of these at their core. It's about supporting people to uphold their rights. It's about people being able to access services. It's about ensuring that we take a rights-based approach, but that the standards are also underpinned by evidence, they reflect practice and they reflect policy. And that's really important. And when you have a broad range of stakeholders, practitioners, clinicians, it might be people from clinical governance, it might be third sector, it will also be with people with living experience. It's really important that we work together and we build consensus. And the standards that we're going to describe today, this is how they've been developed. We have to have really robust governance mechanisms for that. And what we do is we follow international principles for standards development, which outline really clearly the importance of good governance, where you minimize bias, where you take into account robust methodology, so your standards are reliable and they're valid. but also the processes are open and transparent. I think it's useful to outline that. I mentioned before that the standards need to sit within a quality management system, and many of you will be very familiar with the principles of a quality management system, and they're up on the screen there, about listening, about involving, about making sure that we have self-assessment and readiness and understanding the system at its core. So I just wanted to say about how these standards have been developed very much with that quality management system in mind. But standards don't stand alone. They sit in a wider context. They sit in a landscape. And I think it's really useful for us to also outline, to take a moment to describe two programmes of work that are being undertaken by colleagues within Healthcare Improvement Scotland. You'll see on the screen some information about focus and dementia. This is a really important portfolio of work which covers a number of different strands of important work, and you'll see there on the screen the sign guideline around dementia. And these standards take into account all of these pieces of work, because it's really important that the standards recognise, support the implementation of other really important documents, really important policies, and dementia obviously is really key in terms of ageing and frailty. So that's one portfolio, and we have colleagues on the call who can answer any specific concerns or queries or questions around that. The second one that I just want to touch on is the Focus on Frailty programme. Again, a really, really important part of work that Healthcare Improvement Scotland is developing and working with partners around. And as with the Frailty programme, there are key contact details that we'll also put in the chat too, so that if frailty or dementia are things that you'd like to find out more about, because you've been introduced today, Jane and James will put their contact details. So I really wanted to give you that sense of the work, the robustness, that it sits alongside, and it very much chimes. It's been developed in partnership with a range of stakeholders, but part of that partnership is also around the range of programmes that are out there. So that's a bit about the background. I want to now pass to Paul, who's going to talk you through the first part of the standards before he moves on to Paul.
That's great, Fiona. I'd like to start by sharing this 1981 British road sign on the left of this slide, which warns drivers that there may be old people around. Personally, I think it's a bit dated. It portrays a negative stereotype of older people in our villages and towns. And there's probably more need to warn drivers now about pedestrians wearing headphones or texting as they walk, rather than there are people living with a kyphosis and using a walking stick. So a few years ago, there was a Sign of the Times campaign aimed at changing the perception of ageing. And I love the image on the right, which was submitted by one of the finalists, Alan Dye. So in reviewing the existing care of older people and hospital standards that were published in 2015, feedback from over 100 stakeholders requested that there should be a similar change in focus, with an emphasis on prevention, early intervention, and future care planning, bringing in components of community care, social care, and care at the interface, with an emphasis on autonomy and human rights, supporting people to make informed decisions that might involve an element of risk, and with specific criteria relating to dying well, whilst ensuring that a palliative care approach is considered throughout the standards and not just as an add-on at the end. People wanted to keep the style and the format from the previous standards, noting that they promote excellence and encourage services to improve, but with a subtly but important change in scope, so that the new standards should apply to all health and care settings, not just hospitals, but also hospices, general practice and primary care settings, community clinics, and care homes. That they should have a specific focus on frailty and move away from a rigid cut-off age, which might exclude some people living in areas of increased socioeconomic deprivation who may develop age-related frailty slightly younger. However, there was also a strong desire to make it clear that these standards are about ageing and frailty, and they do not cover the needs of younger people living with disability. So these revised standards are entitled Ageing and Frailty, Standards for the Care of Older People. And of course, these are the people most likely to benefit from integrated, multi-agency planning and delivery of care. These new draft standards have been developed by a multi-professional and multi-agency group representing professionals and organisations within the hexagons on this slide. The group was co-chaired by Professor Theo Mayant and myself. Now, almost every professional group is involved in caring for older people with frailty, and so we know that the development group could not include everyone. However, the purpose of today's webinar is to say to everyone on this call, please look at these new draft standards. Tell us what you think, and particularly if there's something that you believe we've missed out or not captured correctly. The draft standards are published on Healthcare Improvement Scotland's website. You have until the 18th of June to give us your thoughts and opinions, and we would like to hear from you. Every comment or suggestion received will be considered and responded to. We want to ensure that these standards serve older people with frailty. And of course, the most important group that were involved in developing the draft standards are those in the middle blue hexagon, people with lived experience. Whilst we had representation from SOPA, who are the Scottish Older People's Assembly, within the development group, we also met with them regularly to hear their views. In addition, we conducted interviews with older people during the scoping exercise. We consulted with Carers Scotland, and we held focus groups as far away as Orkney and Lewis with older people living with frailty. The development group has come up with 11 different standards that we feel cover the important aspects of ageing and frailty. These are service design, which is how services integrate and embed frailty within them. Identification and assessment of frailty. Person-led care coordination and future care planning. Now, future care planning is the term that has recently replaced anticipatory care planning in Scotland. The support for staff and care partners, and the term care partner refers to any person or representative that the individual living with frailty wishes to be involved in their care. Care partners are generally unpaid carers. Standard 5 covers keeping active. 6, nutrition and hydration. And then we've got standard and medicines management, living and dying well, care in hospital, delirium, dementia, cognition, and then finally, mental health. Each standard has a similar format. It starts with an overarching standard statement, and it's then followed by a rationale explaining why the standard is important, a list of criteria describing what is needed to meet that particular standard, and then a series of statements about what the standard might mean if you're a person living with frailty, a member of staff, an organisation providing care, and then finally with some practical examples of what meeting the standard looks like in practice. So, for the remaining part of this webinar, we're going to focus on some of the detail within a selection of the standards to give you an idea of what is new and what has changed. We'll start with Standard 2, which is the identification and assessment of frailty. We know that somewhere between 40 and 50% of people aged over 65 are living with frailty in Scotland, and people with frailty have worse health outcomes. And so identifying these people is important. It's important because targeted interventions can reduce the progression of frailty and can help keep people independent. Health and care, including medicines, can be tailored to meet the needs of the individual, and it can allow important discussions about future care planning and palliative care. Once frailty has been identified, an assessment of need should be undertaken. And how that happens depends on the setting. Of course, it will be easier to do a comprehensive geriatric assessment within a specialist hospital setting rather than during a short consultation within general practice. And so assessments will need to be tailored according to the setting and the experience of the health and care professional. So for Standard 2, we start with a statement which says, organisations have systems in place to identify, assess and plan for the needs of older people with frailty at the earliest opportunity. The rationale highlights the importance of first identifying and then assessing older people with frailty, and notes that people and their care partners should be part of discussions at all stages. There are then 6 criteria for the standard, an example of which is criteria 2.3, and this says that organisations identify frailty using an approach that's based on current evidence, that's validated or recommended by professional organisations, and is relevant to the care setting. There are then examples of what this standard might mean for people, for staff, and for the organisation, with further examples of what meeting the standard might look like. Let's jump to Standard 5, which is keeping active. The equivalent 2015 standard focused on falls prevention and management. This is important because there's high morbidity and mortality from falls. But our development group wanted to broaden the scope so that the revised standard doesn't just focus on falls, but covers mobility, exercise, and meaningful activity. They are, of course, interlinked because keeping physically active improves strength and balance and reduces the risk of falls. We heard from older people who had been told not to do certain activities because they might end up falling. So we have emphasised that people should be enabled and supported to make informed choices about movement and activity. And for some people, that might even be skateboarding. We have also incorporated evidence from the World Falls Guidelines, which relates to a multi-domain assessment, which includes sensory function, cognition, medication, polypharmacy, nutrition, and hydration. So the statement for Standard 5 reads that older people with frailty are supported to keep active, to maintain and improve mobility, independence and function. Our rationale includes a focus on encouraging mobility and engagement in meaningful activities, reducing the risk of sarcopenia, and enabling informed choices about movement. And there are 11 criteria within this standard, one of which is 5.3, which says that staff are trained and supported to promote and encourage mobility and independence in all care settings, to reduce the likelihood of falls, and to provide tailored educations on falls prevention. Now, Standard 6 is about nutrition and hydration, and this topic was not covered in the 2015 standards, but it's been identified by the World Health Organization as a key priority area for healthy aging. Good nutrition and hydration supports muscle strength. It supports mobility, our ability to fight infection and wound healing, and so it's particularly important for older people with frailty. The standards around nutrition and hydration recognises the social and emotional context of eating and drinking, with specific reference to the last days of life, when it's normal for there to be a reduction in oral intake, and yet when care partners may become very anxious and stressed when they are unable to feed the person that they're providing care for. And so Standard 6 starts with a statement that says, older people with frailty have their nutritional and hydration needs identified and met. It then lists the rationale, highlighting some of the points that I mentioned on the previous slide. And there are 11 criteria within this standard, one of which is criteria 6.6, which says people are given the time, the equipment and assistance to eat and drink in line with their informed choices. The final standard that I'm going to highlight is Standard 9, which is living and dying well. Artist George Hardy proposed this image as a replacement for the Beware Older People road sign, and I love it. For me, it depicts two older people who are gazing up to the sky, perhaps looking towards heaven. I think they appear happy and they've plenty of life left within them, but at the same time, they're happy to talk and to consider their future. And we've added a new section within the revised standard that focuses on living well now and right up until the time of death, whenever that may be. Sense of well-being can be impacted by lots of different things, such as visual and hearing impairment, continence issues, and symptoms such as pain and fatigue. And so addressing these can make a huge impact on quality of life and the ability to engage and enjoy life. This standard emphasises that people are involved in decisions about activities that may cause harm to them, such as standing on a red triangle, but they're enabled to make choices in line with their values and their enjoyment. And so we recommend discussing future care planning and considering a palliative approach to care much earlier, not just when someone is dying. Older people with frailty will often have thoughts and questions about their future, and professionals should be receptive to these and feel confident in discussing spiritual or cultural aspects of care, as well as death and dying. And so Standard 8 starts with a statement that says, people's well-being and enjoyment of older age is maximised and they are enabled to live well until the end of their life. And the rationale focuses on the importance of feeling valued, respected, and able to undertake meaningful activities, and why it's important not to block discussions about spiritual or cultural matters, including death and dying. There are 11 criteria within this section, and criteria 8.10 says that people are enabled and supported to have honest, compassionate conversations about living well with deteriorating health, to have early discussions about palliative care and the support available for people and their care partners, to have conversations about what happens when someone is dying, and to have information about care and treatment options when they are dying. I'll now pass over to Theo, who's going to highlight another 3 standards and explain what difference we hope that these standards will make in practice.
Thank you, Paul. I will take you through a few standards which we thought worth highlighting. The first one I'm going to talk about is standard number 9, which is care in hospital. As you all know, there is this is covered in 2015 standard as care of older people in hospital setting. So much of the standards criteria have been retained in here, but there are a little bit, I think there is also better recognition about the challenges the older people face during the hospital stay as well, not just in medical wards, but also all clinical areas. So the focus is very much around in all hospital care settings, and in terms of assessment, and also focus around access to specialist team as well, because we know that there is a uniformity across Scotland in terms of access to specialist team, such as surgical liaison or orthopedic services, so or other geriatric services. So I think that that's one of the things we very much bear in mind when we develop this standard. And also some focus around delayed discharges from the very beginning, where discharge planning. Also, those who are experiencing delayed discharge receive the high quality, equitable access of care. They're not just sitting somewhere in the corner of the hospital. I think there need to be, so the focus has been regular review and making an active engagement with the multidisciplinary, multi-agency stakeholders to get their discharge timely, really. So I will move on to some example of this standard. So standard statement said, frail older people in hospital receive the equitable, compassionate, and safe care that promotes well-being and reduces the risk of harm. So that again, I will stress again, it is for all patients, all older frail people in hospital, not just under care of the elderly department. I mean, obviously, we know that frail older people are major user of hospital services, and we know that there are a lot of harm that can happen during the hospital stay, and they may decondition as well, and they may, the frailty may get worse as well. So at the same time, there's a lot of opportunity to prevent it happening. Also, from our Scotland-wide audit work, we know that comprehensive geriatric assessment, when offered as early as possible, actually linked to better outcomes such as shorter length of stay. Give you the standard cover about 10 criteria, and I highlighted 2 criteria here. The first one is that NHS boards should have the appropriate risk-assessed frailty pathways for older people, frail older people in all hospital areas. So that's the kind of the key element of it, really. Anyone who are in hospital, who are in contact with hospital services, should have that clear frailty pathways. And second point, focus on screening and assessment, and also access to the multidisciplinary frailty team as appropriate. So I think we acknowledge that number of geriatricians are limited, and it depends on the part of the country, which part of the country you live in as well. There's a huge variation in number of geriatricians or multidisciplinary team members across the country. So again, going back to Fiona's point earlier on, that every criteria need to be assessed, need to be implemented depending on local circumstances, and potentially there may be opportunity to improve the services and staffing level for that matter as well. So moving on to next standard, it's about delirium, dementia, and cognition. We put this as the development group, when I refer to we, put this as a separate standard because these are important conditions common in older people, and that these conditions put them into the much more vulnerable state as well. So they're already frail and older, but if they have these conditions, they are more vulnerable and they will need extra support. And we're very lucky that we have the Science Dementia Guidelines, which we take evidence and learning from that in this development group work. And I think the focus again is on the early diagnosis and support in the community as well as all health and social care settings. So because early diagnosis will allow us to do prevention and also appropriate management. So wherever they are, we are encouraging people to have the dementia-friendly setting, either in care homes or in hospital. And also there's a recognition of delirium and reduction risks. It's important when people being moved between wards, which is not infrequently happening this day and age, and also moving one setting from another. So whichever way, really, community to hospital or vice versa. So Standard 10 has 9 criteria, And the standard statement is older people experiencing a change in their cognition or mental state are identified, understood, and supported. So the rationale is, we know that older frail people are higher risk of delirium, and delirium is associated with several poor outcomes, such as falls, longer hospital stay, and mortality. And also, older frail people with dementia are also higher risk of delirium, and compounding further and increased risk of all other complications as well. So there's a very clear rationale why these conditions should be taken seriously in all settings when it comes to frail older people. And I'm highlighting here the criteria one, which is about the identification and further assessment. The focus here is having a holistic approach. It's about, and also obviously this assessment is more of, it could be at different level, because in the community, it may be just worrying about something, which will kind of reflect to the appropriate health and social care services. So depending on the situation, the assessment or identification may be slightly different, but the whole purpose is having an assessment as good as possible and make an appropriate referral. So it may include things like cognition tests or more complex neuropsychological batteries, and they should happen with the information from care partners and staff member, as well as the person's circumstances and experiences. The final standard I would like to highlight is on mental health. They, again, very much like previous condition, dementia, delirium, and cognitive decline, people with mental health, we all know that they may face difficulty when they are trying to access the healthcare, and they may need extra support as well. And we know that dementia is relatively common in older people, and there is a link between depression and dementia, and it goes both ways as well. This standard also highlights the importance of medication reviews in these patient or population, because they may be put on psychotropic medicines, etc., antidepressants, anticholinergics, and therefore the need for review medicines at the appropriate time. So the statement, before I go to statement, this standard has 9 criteria. And the statement said older people with frailty have their mental health assessed and supported. The key thing here is the recognition that older people may have mental health condition which they have lived with for their lifetime, or they may develop them later in life, or indeed even during the acute illness episodes. So also we know that depression is common, or loneliness particularly common in frail older people. So, and also there is an anxiety element. They may display anxiety, but that may be undiagnosed or normalized as an appropriate response to acute illness. So that's why we have identified mental health as a separate standard, so that there are specific criteria to deal with for older people, frail older people with mental health conditions, which are either acute or enduring mental health conditions. So there are 9 criteria, as I said earlier, 8 criteria, and 11.1 again focus around assessment and recognition. And then I think one thing I want to highlight is it's for mental health, it's not just about assessment, also about planning, ongoing care planning, and particular focus around change in care setting as well. That could be very unsettling for people in mental health. And also importance of person focus and their autonomy, therefore communication and shared decision making as well. So I think there are huge amount of opportunity based on these standards, and that's why we want to make it perfect. So therefore, we really like to hear your comments and feedback, because this is a really good opportunity to make sure as good as possible for the services, not just healthcare, also social care services for older frail people in Scotland. So this standards, hopefully, we hope that will act as a catalyst to develop services, either new or evolve the services to meet the standards. And there's a huge opportunity to train the workforce to meet these expectations as well. And also communicate between health and social care partners more openly and transparency in care, and sharing information appropriately and learning from each other as well. The final point, which is probably extremely important thing, is biggest opportunity to identify frail older people early, so that we can prevent decline or even reverse it if possible. So this is going to be a few final slides, going through some impact of aging and frailty standards. I think obviously safety first is it's the key aspect of all clinical or social care services, and these standards provide a benchmark for health and social care professionals in caring for older people, and adherence will make sure less errors or zero errors, and therefore safety of care provided. I think this safety goes beyond the person who receives the care, also the care provider, also organization, by providing safe and high quality care. I think there's a lot about, working in a safe environment within the multidisciplinary team, and benchmarking your work with the standards, and also knowing that you're doing your best to the highest standard as the people will expect, will give moral boost and professional pride as well, I think. Very importantly, again, as Fiona highlighted early on, equality is the big thing. It's difficult to get equal opportunity or equal access to healthcare, and having these national standards, we hope that will ensure equality for frail older people wherever they reside. And obviously, having the standards as a benchmark, all the services or teams can self-assess or evaluate their quality, and it will form as a governance indicator to continuously improve the quality and safety of care. And by doing these things, I think it needed to say the efficacy and effectiveness will be improved, and then the healthcare system, and that would be reduce the complications, improve the outcomes, which is the ultimate goal of being in health and social care profession. And also it will help the services to benchmark themselves as well and monitor their performance year on year. And the professionals may seek certification for their professional development, knowing that by doing that, they are doing the good job and helping people.
Hi, I think we might have lost Theo there. Apologies if we have. So sorry about that. Hopefully he'll be able to. I put in the chat, I've got a thunder and lightning storm above my house. So but we lost you a bit there. Did you want to just finish up what you were saying now? It's lovely to see you back.
Which bit do you think missed? Sorry, I
Last
can't hear
30
you.
seconds. Last 30 seconds,
Oh.
I think you froze.
Okay, hopefully everybody can hear. And I think I probably covered the first slide. So I will refocus on this slide. Sorry about that. So where obviously you have read this slide. So needless to say, at the end of the day, these standards, we hope that will improve your quality of the services you provide by having a continuous clinical governance and quality improvement project. And there's a lot of opportunity to do a lot of quality improvement project across the board, both health and social care. And by doing that, you know, the services we provide are going to be efficient, effective, transparent, better communication between different sectors and agencies. And also that will help to improve the clinical outcomes, which is the reason why we are here. So with that, I will pass on to Fiona. Thank you.
So thanks. That was really, really informative to both of you. A really comprehensive talk through the process, the robustness, that people with living experience really being at the heart of this, about the partnership working, and some detail about what's included in the standards. There has been a lot of chat that's pinged up, and Paul, thank you for responding to some of that chat as it went through. I wonder if we just take a few moments to go through some of the questions that have come up in the chat. I've tried to sort of keep an eye on them. What we can do is we can respond perhaps in a more fulsome way to some of the questions. I think that would be really helpful. But there were some really important themes that kind of have been touched on. There was a bit of a flurry at the end there. The link will indeed be posted in a week or so's time, so we'll absolutely make sure. And perhaps what we can do then is I say, have that more fulsome response. So Pio and Paul, and perhaps others as well, if you could. If I'm going to, if you forgive me while I look to the screen. Say some of these were responded to in the chat. So there was one of the questions was about how we've captured the views of those frail adults with communication difficulties. Do you want me to say something on behalf of the project team, Paul and Pio, or do you feel okay? So we are not quite finished consultation, but we have done a number of targeted sessions with people with living experience. We're working also with the Alliance, who in the next short while are going to be doing a focus group, and we've got some BSL translators, interpreters who are going to be part of that session. And we've also gone out to care homes and spoken to people with a range of communication challenges. Not everybody has fully completed the survey yet, so there is some ongoing work for us to do, but just to say that we engaging with people who are seldom heard, engaging with people who are underserved is a real key part of the standard. So we can give you more of a fulsome answer to that, but I thought it was just really important to let you know that that's absolutely where we are. There was a question in from Christopher, which was around EHCR, and Paul has popped a response in that. Paul or Pio, is there anything additional you would like to say to Christopher and others around that?
I'm happy to comment. So, you know, electronic healthcare records is something that we really do need to progress, you know, within Scotland, so that, you know, wherever someone is receiving care, and quite often people are receiving care from a variety of different professionals, that there's a way that we can share and communicate assessments, easily between each other. So there is work that's progressing on this, to have a national clinical record. I must admit, I'm frustrated. It's a lot slower than I hoped it would be when it was first started talking about this 5 or 10 years ago. We're not there yet. And so because we're not there yet, we need to use other ways of sharing information and communicating between, different providers of care. And at some point in the future, I'm sure we will have an electronic single health and care record, where we can communicate a lot easier. But because we're not there yet, we need to look at using other methods to share information and communicate.
Thank you, Paul. Another question came in around this work, and it's actually a theme, so I'm going to bulk a few up. It's around other pieces of work that are out there. So there was one around how these standards integrated with existing work from Care Inspectorate and things like the healthcare framework. And again, Paul, you've put in some discussion around that, and absolutely these standards read alongside all these key pieces. There's something in the chat too around how we've worked with care homes and how we've worked with the care sector, and that's again been something that we've really wanted to ensure that we get that right, working with the Care Inspectorate, and we can again share details of who we've engaged with in terms of the care sector, because I think that would it's really important that we do that, and we've done a lot of that work too around that, so we can share that with you as well after this. So Paul and Pierre, is there anything you want to say about how this either links with other key policy documents or how this links with other sectors, and that might answer some of the questions that are there?
Sorry, there's a question about why dementia and delirium being combined, these standards. So yeah, so it is quite a difficult thing in terms of setting standards for all settings, and with the new additions of some standards, so we come to the conclusion that we will put them together because there are different conditions that we recognize that dementia, delirium, and cognitive decline have a very specific meanings and specific, but these are common presentation, and especially people with the background dementia will have the high risk of delirium when they come to hospital. So that's what I recall as having a kind of some pragmatic grouping as well, and not having 20 standards. So we're kind of trying to keep the numbers in a reasonable range, as well as trying to be yeah, so pragmatic about it. I don't know whether Paul want to add anything.
Not about that, Fio. I'm happy to answer Fiona's earlier question though about the, where these standards sit. I think it can be quite hard when there's lots of different standards, across health and social care. What we tried to do was not to duplicate existing standards. So someone asked about health and social care standards. Now, yep, the health and social care standards should be read alongside these. So we've not recreated or tried to update the health and social care standards. What we've done is had a particular focus on the needs of older people with frailty, and have a think about what, in addition to the health and social care standards, what else do we need to do to make sure that older people with frailty are receiving the right care, whether that be in a care home, in general practice, in a community hospital, or in a hospital or hospice. So they should be read alongside these other important areas. And we listed at the beginning of the draft standards on page 5 and 6 a number of key documents that we feel that these standards sit beside. Please have a look at the draft standards as they are published, on the Healthcare Improvement Scotland's website.
Thank you. So I'm thoughtful of time, and that's a beautiful segue into the next slide. So we'll take the comments that are in the chat. Some of the questions we haven't been able to get to yet, but we will go through those, some really helpful comments as well. So the consultation started in April and runs to the 18th of June. And we really want to hear your views, and the questions and the feedback that you've shared with us today will be part of that consultation feedback. And as was mentioned earlier, every comment is considered by the development group and every comment is responded to. And what we do is when we publish the standards, we also publish that log, which is this is what was the feedback and this is what's done with the feedback. So we're very open and transparent. In terms of how to participate, there's an online survey through the Healthcare Improvement Scotland website. We are able to support some more personal engagement as well, more face-to-face, whether that's with groups of people who are staff mix, or it might be, for example, third sector, or it might be people with living experience. So there's a range of ways that we can do that. That might be one-to-one, that might be focus groups. We tend to go out to individuals rather than people coming into us. We're also very thoughtful about digital exclusion. So there's a range of mechanisms that we would use to make sure that people's voices are heard throughout this. And we also support organisations to do that on our behalf. And the Alliance is supporting us with it, as other organisations have been. The details are all on our website. The consultation link is there. If you type in Healthcare Improvement Scotland or you type in Ageing and Frailty Standards, it will come to us. The email address is also there for you to get in touch. It's really important that we hear your views. You will help shape these standards. You will help make them reflect the experiences, the expectations of people who are trying to access services, their care partners, but also for the plethora of staff and volunteers who provide support to people experiencing ageing and frailty. So it's really important that we hear your views. This is part of that capturing of those experiences and that feedback, but there are other ways too. So thank you very much for attending today, for all of those who have supported the organisation of it, particularly to Paul and Pio for your contributions and leading us so thoughtfully and so insightfully through the work. It is an enormous piece of work, and they have steered a multidisciplinary development group with great skill to get to these standards. I was delighted to read some of the comments about breath of fresh air, really looking forward to it. Some of the devil will be in the details, some of the questions that were asked. I think when you go through the standards, you'll see where that comes real. Just a reminder, as I say, we've until that it is about a week or so that we'll be sending the link to this. Please share the link to this webinar with your colleagues. Please share links in terms of the consultation feedback. It's really important that we deliver on this work and that we raise awareness. And so you have a really pivotal role, and a bit of a clarion call for all of you to support us in that. So thank you very much. We are finishing on time, and that's partly due to the diligence of Paul and Pio and your presentations being so to time. So thank you very much, and we hope that you'll participate in the consultation, and we look forward to sharing you the final standards later on the end of the calendar year. So thank you very much. Thanks, everybody.